So basically, we wanted to give some tips and give some deeper insight how we can deal with peri-implant cases, peri-implantitis cases. That mainly we have two different categories. So the one is the biofilm-induced peri-implantitis. This is the primary typical causative factor, which is typical for periodontitis patients. And the other is where we can see some biomechanical complications that, for example, the abutment was too deeply located, and with a proper change of the abutment, probably we can, so probably in many cases, the angulation, the form, the too over-contoured profile of the abutment is also an important factor. But to be honest, the vertical dimension, if you do not go too deep, then probably it can help out conditions where a peri-implant bone loss starts to develop. And probably we can also somehow demonstrate that in more of the cases, not only the biofilm and not only the periodontopathogens, but some more critical factor can be mentioned, and more or less this is the prosthetic part. So we have three different factors coming together or in one group, and these are the biological complications, the biomechanical complication, and then the direct access from periodontopathogens to the implant surface, and these cause the peri-implantitis. I wanted to highlight some cases where we can say that a peri-implant mucositis existed, but on one hand we have the keratinized mucosa, and on one hand we have the peri-implant deficiency, the soft tissue is not even enough. One more case where previously no buccal keratinized mucosa existed, and that was the reason to lose the bone. And by saving the condition with a prosthetic modification using abutments, probably we can save the condition. Here we can say that this is quite obvious that we have an inflammatory process, but on the other hand, you can also see that the keratinized mucosa is not given lingually, so the lingual part is too narrow to work correctly. So these implants were placed by me, and someone else did the prosthetic work. I do not want to complain the other, but I think the prosthetic work was also somehow a key factor to developing this radiographic bone loss. And once again, if you are facing to elevated BOP levels and suppuration and recession, then this is quite obvious that we are facing to peri-implant disease. One thing should be mentioned and distinguished from the others, and I think this is the peri-implant acute condition. It could happen that during re-entry procedure, somehow the site will be infected, and if we do a very early treatment, and for that case, I think this peri-solve and Hyadent complication could be very effective. We can save the condition. This is not the case when an absolutely misfitting prosthetic work with the abutment and with the crown will come. And the worst case scenario where we have multiple defects, and this is due to the fact that the periodontopathogens without follow-up tends to repopulate all the implant surfaces. The bad oral hygiene can be also mentioned. And if we can find the center of the inflammatory process, then probably the others can be treated correctly. As you can see here, there is a confluent defect configuration where two implants, neighboring implants, were involved. One implant can be probably saved when we remove the other. So these are the main things to be mentioned, and probably we can speak about the possibly the best treatment option from peri-implantitis when we have the defect outspread of the vertical length up to 1/3, or just a starting peri-implant defect can be recorded. When we can have the opportunity to use in that treatment option, for example, the peri-solve Hyadent concept, probably we can get a proper regeneration if it has outspread up to the 2/3 or even more. As you can see on the neighboring slide, then probably only the implant removal will be the case, but between the 1/3 and the 2/3 surgical access, and if we have a ideal vertical defect configuration around the implant, then probably we can have a very nice healing. So the non-surgical at the beginning up to 1/3 therapy is very, very simple. Also very simple when we are facing to a condition where the bridge work was holding the implants in place. So we can say that non-surgical therapy could be a very simple procedure, bridge removal, and we can easily have the site that can be later re-implanted if we do some reconstructive surgery on the same side. Probably if the implant was placed not by us, by someone else, and this is the case, and this is the simplest procedure. Some more tips how to deal with these defects. Let's go to a typical configuration where we have a huge infection. I think this is an absolutely great C type of infection, where the infection vertically and also horizontally have a certain and very fast outspread effect, and the neighboring implant was also involved. The absolutely hopeless implant was explanted, and this is the condition after explantation. I waited 2 weeks, and then a buccal bone artificial extension was performed, as you can see here, the healing process, and then this is the final outcome. This is before, and this is after, and here we can see the 11 years follow-up. Between 1/3 and 2/3 reconstructive surgery is needed. We can use for the pre-treatment protocol the peri-solve concept. When the inflammatory process, the bleeding on probing starts to get reduced, we can go for the reconstructive surgery. The flaps will be raised and mobilized in a way that a complete closure above the previously opened implant could be achieved. Proper cleaning, then high-dent hyaluronic acid application, some autogenous bone chips to cover up the margin of the defects, and then pericardiac membrane was placed. After proper healing time, abutment connection with some tuberosity graft to create a proper soft tissue profile, and then once again the problem occurred. The same issue that we wanted to have a little bit individually formed prosthetic work, and this caused an acute flare-up of the defect, and therefore, once again, peri-solve was applied. After the appliance of peri-solve, a diameter-reduced crown was positioned, and we could achieve an eye healing after this therapy. Some typical cleaning effect you can see before and after the non-surgical therapy, as was presented before by Vincenzo. You can see the concept, proper diagnosis, mechanical debridement, application of peri-solve, and then the hyaluronic acid, stepwise once again. And here you can see the tables for the final result. And probably it's quite obvious that the bleeding on probing can be reduced by using this type of application compared to the control, where the bleeding on probing was much less reduced. And finally, some cases where we can compare that if we do not have a very advanced defect configuration, we can have a very nice healing. That was the acute treatment. Only peri-solve was applied. Here, peri-solve and abutment modification would help. And here we can say that not an alone-standing surgical procedure, 2 different surgeries. The one when explantation and extraordinary artificial bone was created, and then some further peri-solve application. And this is probably a very nice final case. I'm sorry, this is not my with my presentation. This is another presentation right now I see. This is the final case what I wanted to present to you. One implant completely failed and the neighboring tooth was also presenting a furcation 3 defect. So the tooth was extracted and processed in a way that from these tooth autogenous tooth originated bone graft was utilized, the 2 implants placed, and on the other side where the implant was completely hopeless, we removed the implant and used this autogenous tooth graft to fill up the explanted site. And on the neighboring implant site, Perisol was several times applied, and this is the final outcome. So with the same regenerative approach and combined with Perisolve, we can finally result in a completely healed configuration where the bridge work was used as a temporarization for that time that later an implant will be also feasible to place. Many thanks for your kind attention. And if you have some questions, please.